Hello everybody, welcome to Beginner's Econo channel. Today we are going to see an interesting topic. Before going to the topic, let me give a case scenario. Just imagine when you are posted at the emergency room as a student nurse, you receive a patient at the ER with signs and symptoms of loss of consciousness, headache, there is a massive head injury, with followed by tibia and fibula fracture, with the attender in a panicky state. As a nurse, what you would do? Handle the attender, scream onto the patient, scream yourself, or you're going to call in for a doctor, or you're going to do the assessment such as ABCDE. Yes, my dear student nurses, I would like to say that you people should never ever panic in a panicky situation, because here we are the nurses going to be acting as an advocate as well as planning the patient care. So we are the golden angels near the patient. Imagine we are not going to panic even in a panicky situation. So first and foremost, just reassure the attenders and stay in a calm, tell them in a calm way to wait out until we screen out the patient, what is wrong with him and what can be done with him. Yes, after you separate the patient and the attender, now it's the time for the rapid fire round. What is it? Never wasting time assessing the airway, breathing, circulation, disability, and exposure. In airway, the first one, you're going to clear the airway whether it is patent or not. If it is not patent, then try to do the maneuvers such as head tilt and chin lift maneuver or jaw thrust maneuver, or you can plan it for insertion of LMA mask. And after insertion, or you receive the case immediately, once the airway is being cleared and patent, just check it for if there is any edema or if there is any obstruction, visible obstruction in the upper airway or in the lower airway. And we have to plan accordingly. Once you have sat down with that, then check the respiratory status and also check in for the adventitious sounds or if there is any noisy sound that you can hear at the breath rate. And if not, just move on to the breathing pattern. In breathing, you're going to assess the SpO₂ saturation level, how the patient is breathing, whether both the chest walls are bilaterally opening up and down, moving up and down, which shows that the air entry is equal. In case if you find asymmetrical, that might be indicate a cause of a head chest injury. Then we have to plan for some other procedures such as insertion of ICD, or might be the patient may need an emergency thoracotomy. Then in the breathing, you are also going to check whether the patient is apneic. If the patient is apneic, ventilate the patient either by intubating the patient with endotracheal tube or might be a tracheostomy. Then starting with the oxygen. So next comes after the breathing being accessed, you're going to assess the circulation level. So here the circulation level, you're going to skim and scan the patient very rapidly and check whether the patient is having a good peripheral pulse or is there a bounding pulse or a weak and thready pulse. So accordingly you can plan whether to start on with the IV access. So of course here you're not wasting the time putting the IV. If the patient is IV access is very readily easily seen. If it is very tough, then we may plan it for intraosseous, that is into the bone be transfusing. Then you also check in for whether the patient is in the signs and symptoms of tachycardia or hypotension, that is reduced PP, which is showing that the patient is in hypovolemic shock. Then of course in this time you're going to start the IV access, connect the patient to the monitor, check the rhythm, heart rate and the SpO₂ saturation by connecting the patient to the SpO₂ probe, to a rapid BP assessment as well as temperature assessment. So in this you will come across that the patient may have decreased BP, and accordingly you are going to start it with the emergency drugs in case vasodilators is needed, or maybe it is due to some other condition that is due to loss of volume from the body due to the trauma. So start in with plasma volume expanders or isotonic or hypotonic or hypertonic solution according to the serum electrolytes level of the patient. Here we are also going to do a rapid ECG and a chest x-ray if necessary and an USG. So when you're going to assess the breathing after intubating, you're also comparing with the EtCO2, endotracheal carbon dioxide level, USG if necessary, according to the wound site, chest X-ray if necessary, according to the chest area being exposed for wounded, and a CT according to the area where the patient had developed wound. Then, along with that, if necessary, you are planning to start with blood transfusion. So, in blood transfusion, we have to know the blood grouping and the typing. If it is known by the patient, then we have to arrange for blood transfusion. If it is not known by the patient, do an emergency rapid blood test. That is the blood, the grouping as well as RH typing, and cross matching if necessary. Then the D stands for disability, or you call it as the deficient. So to analyze the neurological status, you're going to rapidly do the above scale, alertness to verbal response, whether the patient is responding to pain and whether the patient is unconscious. Then of course you can also plan for a rapid GCS assessment, checking the motor skill, checking the verbal skill, and also checking the eye response. Of course, you're going to assess with the torchlight, checking the pupillary responses, whether they are equally reacting to light and accommodation. You do a rapid blood glucose assessment, do a rapid neurological assessment of all the cranial nerves and the motor function and the sensory function. Also, you also assess the posture of the patient, whether the patient is able to maintain the posture, and if necessary, if it is due to any other reason, like be snake bite or insect bite, or patient is having some organophosphorus poisoning, then we are also doing a rapid toxicological examination. Meanwhile, you're rapidly assessing the random blood glucose level, and if necessary, if you know the poisoning agent, you're going to start on with the antidote in the deficient area. And if the patient is unconscious or semi-conscious, accordingly, you're going to enhance the safety of the patient by putting the padded side drains so that they are not being injured whenever, even during after head injury, there is high chances for seizures where patient can fall from the bed, and that's the reason you do that. And of course, we see in the E is that exposure. So exposure is that it's nothing but it's coming under the secondary survey where you do the head to foot assessment, checking the temperature of the patient, asking the past medical histories if the patient is aware of like maybe known diabetic, known hypertensive, etc. Checking out the other injuries except the tibial and the fibular region as I told you, checking other areas, and also asking the signs and symptoms of any other drug usage, skin changes, as well as infections in the patient. Of course, in the exposure period, you're going to start with the nursing care, that is, if necessary, starting with NG tube insertion, or you're going to do the stomach decompression in case of a poisoning, and other sorts of medical procedures, such as POP in case of a fracture. The secondary survey is that it states with the sample, that is S stands for the symptoms of the patient, whether it is aggravating or whether it is degrading or it is still in progress. And A stands for checking in with the allergies of the patient, whether medical allergies, medication allergy, environmental allergy, and so on. And then in the P stands for past medical history, L stands for the last meal what the patient has taken in, and E stands for events, that is relating to the incidents. Might be what was the provoking factor to develop that particular changes in the physical status. And we also do a rapid head to foot assessment in the secondary survey, checking for any scalpel injuries or any primary frank bleedings, as well as we check in for any fractures of the facial bone. Then in the neck, we'll be checking for any tracheal deviations, checking for edema, and also checking for jugular venous distension. Then in the chest, we'll be checking for the contusions and fractures over the chest, anterior, posterior, and lateral. In the abdomen, we'll be checking for the abdomen and guarding sensation and distension. And in the pelvis, if there is a frank bleed or instability. In the limb, we'll be checking for the neurovascular status as well as the fracture. And when you're assessing the back, you just do the log roll because there is chance of spinal injury, suspected spinal injury. To conclude, we being the student nurses at the emergency department, never panic. Always time saves life. Never ever waste even a single minute whenever you receive the patient. Be very spontaneous, not monotonous. Do the right action at the right time. This will also initiate a good life and the patient's life will be improved and the death rate of the patient might be reduced. So thank you for being your close attention. Let's start the ABCD guidelines and keep in your mind, keep in your hands when you're in the emergency room. Stay tuned for new videos. Thank you.